This is a slide I often show to medical students. What's the problem with osteoarthritis? Why don't we have any treatments? We need a reality check here, and I use osteoporosis and other common age-related musculoskeletal disorder for which there are multiple treatments. And I think, part of this has been biases, ageism, agnosia to the problem. But importantly, there's a major technology gap. We've had no DEXA scan for osteoarthritis. And also importantly, what I call heuristic errors. In the 20th century, osteoarthritis was really viewed according to the risk factor profile, old age, overweight, joint injury, and so forth, and became characterized as a disease of wear and tear. And primary or secondary, you might remember having to learn these lists. In the 20th century, we started trying to measure it, and the heuristics were driven by the KL score, which actually was a global score, but we couldn't measure that really well. So experts started measuring the joint space width, which could be done more precisely, and whole careers were spent characterizing how to do this and the measurement and error inherent in that, and new techniques to improve the reliability of the measurement and so forth. And this solidified a notion that osteoarthritis was a cartilage disease. And in a way, we're still doing this. We have precise measures of cartilage, and we're still recapitulating that approach. But towards the end of the 20th century, of course, we have MRI and more biopsies, clinical studies, and so forth. And it became apparent a lot more tissues are involved in osteoarthritis than just cartilage. And that led to some pivotal publications by giants in the field, Ken Brandt et al. Osteoarthritis is not a cartilage disease. And it became characterized as joint failure, in which you have reciprocating pathologies in numerous tissues that lead to this multifactorial and complex disease as now defined by the FDA. We recognized OA as a whole joint disorder with multiple pathways that lead to this final expression, but also note that it had wide-ranging clinical appearances, which were known as subtypes initially, later phenotypes, now endotypes. But on top of all this, there was a need for an all-encompassing conceptual model that would integrate the numerous pathophysiological pathways to OA with the plethora of clinical manifestations in a way that ideally yields treatment targets to achieve disease modification. So now disease modification is the buzz term. But what is disease modification? What even is a disease here? I looked it up actually. A dictionary defines a disease as a condition of a living animal in which one of its parts that impairs normal functioning and is typically manifested by distinguishing signs and symptoms. So in osteoarthritis, this is constructed as follows. You can see distinguishing signs, which generally physicians and scientists look at the clinical manifestations, radiographic, MRI. But in terms of normal function, we think about pain mainly, but other important components are function, sleep, activities, mobility, travel, employment. And we view the former as, I've got these the wrong way around, but normal function, we view these as PROs, the former as pathology. And in the traditional paradigm, the pathology leads to the PRO outcomes. And from all this, we kind of have a construct of disease severity. What's the severity of the osteoarthritis? Some combination of these distinguishing signs and impairment of normal function. And we've kind of translated this, morphed into a construct of disease progression, where the pathology predicts worsening in the PROs. Now, there are many problems with this. To measure progression, ideally, we have a scale you can see mild at one end, severe at the other, and we should have a reproducible and consistent way of measuring disease severity as people progress along this pathway. But actually, in osteoarthritis, we don't have a single or composite measure that reflects, innate overall severity. And partly this is because of the well-known, almost truism now, that there's a poor relationship between these structural features and patient-reported outcomes. In fact, it's not just that there's a poor relationship, it's actually worse than that. Funnily enough, reducing pain can actually increase structural progression. And this has been demonstrated actually in numerous scenarios. So we've got this sort of dichotomy between structure and PROs. And this leads to a philosophical problem because we currently view a requirement to modify both in order to have disease modification. It's a bit of a can of worms because actually change in PROs and function improvement should be the goal. I don't think people care what their knee x-rays look like. They care about the pain and how it's impairing their life. So, and the other philosophical question is if, these two poorly related sets of features of OA are both needed, what really is the disease? And puzzlingly, in order to achieve disease modification with influencing both aspects of disease, you could actually have to target two tissues. And in fact, there's empirical evidence to support this, with some trials showing effects on one target, not affecting PROs, and vice versa. So if you think about it, the contemporary structural measures aren't really process measures at all. They reflect accumulated change or accumulated damage. Indeed, really they're proxy measures of severity. Joint space width is a proxy measure of overall severity, but it was misconstrued as the disease. OA became cartilage loss. Yet it's not a measure of process, and it's led to some empirical problems. Now, as it happened, as I'm going off on a tangent, total knee replacement is somewhat appealing as a measure of disease severity endpoint because it does integrate structure and PROs. But as we all know, and I'm not going to go into details, it's highly problematic as a outcome for clinical trials. And it might be, in fact, usable if its incidence was higher. So a number of groups are actually trying to determine an alternate sort of endpoint. And because there's been some controversy about what we should call it, I'm just calling it the end of the road, an end of the road endpoint. We actually did this back in, I think, 1986. Jeff Dryban took a measure that had been developed by Escobar to define joint replacement appropriateness, had then been used by Dan Riddle in the OAI, and then we changed it heuristically, not to predict knee replacement, but just to define a kind of consistent endpoint. And we validated that, and actually in collaboration with Klaus Flexenhauer and Janina Reed, who were at Sanofi at the time, we actually modeled it and showed that it allowed for substantial decreases in the sample sizes needed in clinical trials. And other groups have done this, and there's the Kim publication and so forth. So that's something of great interest. But going back to change, which we've used as a proxy for disease process, Kale, grade change, JSW change, cartilage volume change are all used, and here's an example. But actually, it's problematic. And the other big problem for us is that the time course of osteoarthritis progression is very long. In fact, we looked at it in the Osteoarthritis Initiative, and over 8 years or so, very few people actually progress. So if you're going to do a clinical trial, you really need to study people over many, many years. But what's typical or usually feasible is only 2 years, and you can see it goes from here to here. And ideally, we'd want to be able to study much shorter periods of time in order to do consecutive trials and drug development. But here's the other problem. Reduction in rate of structural progression, which seems to be the current treatment goal, doesn't actually mean improvement. In fact, worse than that, you could actually lock people into a prolonged, unacceptable symptom state, which would be worse than actually just having a joint replacement. So what might be much better would be to have a predictive biomarker so that you might measure a period of time prior to the development of clinical disease and have that predicts what happens down the line in terms of symptom state by some definition, some global definition, or even end of the road. But these predictive biomarkers need to have high sensitivity to change, demonstrated to have discriminative validity and clinical validity. And that's very difficult, although we are moving to, there are technological barriers, but also potential solutions. And I think we've heard about some of those already. Here's the other big problem. I've talked a lot about structure, and people talk about PROs as if they're also, the benchmark, but actually measurement of PROs is also very difficult, and we're obsessed with pain, which is the most difficult. And with regard to pain, the biggest problem is there's another organ getting in the way. Here it is, the brain. The brain is getting in the way of our ability to measure pain. And that's because pain is highly subjective, individual, and contextualized within the CNS. The signals are modulated in the nervous system and the CNS. And as a result, you get, and I learned a new word from Tahina today, nociplastic, and you get sensitization in pain states. And all of these lead to tremendous measurement issues, which have been very well characterized in meta-analyses of clinical trials, as you see above. And as a result, the pain state often bears little relationship to what's going on in the knee. And it may be relevant that it turns out that 20% of patients who have arthroplasty still have pain after the arthroplasty. Makes you wonder about a sort of phantom knee pain phenomenon. And the other inconvenient truth, as we do trials focusing on the one knee, it turns out that people usually have another one of them. They have two knees. And we rarely take that into account. And the two knees play in to all these issues with the nervous system and the CNS. So that adds complexity. So that's kind of been a high-level attempt at paradigm busting as a way to, have a disruptive perspective on things and perhaps generate new approaches. And rather than listing the 100 challenges and obstacles in this field, I've just listed 3 high-level concepts. I think we have cognitive interference still intruding from the outdated heuristics of OA, especially of OA as a cartilage disease. I think we have a complete absence of a unified core measurement of clinical severity, and perhaps that should be our #1 priority. And we have a lack of understanding of the relationships among process, structure, and PRO relationship, and we still don't take into account the fundamental processes in osteoarthritis. So thank you very much for inviting me to participate, and I'm looking forward to a lively discussion.